Good evening, everybody. I, Dr. Asavri Sawant, welcome you to the live panel discussion on beat blindness, creating glaucoma awareness through early detection, on behalf of Voice of Healthcare, powered by Zydus Life Sciences. So, World Glaucoma Week is a unique initiative that puts a spotlight on glaucoma as the leading cause of preventable, irreversible blindness worldwide. The prompt diagnosis and treatment of glaucoma can prevent needleless vision impairment. However, so many people are still unaware that they have this disease. So, to spread awareness on this very important topic, we have leading subject matter experts with us today. Please let me welcome Professor Sushmita Kaushik, Professor of Glaucoma Services at Advanced Eye Center, Postgraduate Institute of Medical Education and Research, Chandigarh. And she is also the Secretary of Indian Pediatric Glaucoma Society. Welcome, ma'am. Next, I'd like to welcome Dr. A. Murali Ariga, Director of Swamy Eye Clinic, and he is also the Director of Chennai Glaucoma Foundation. Welcome, sir.
Thank you.
Next, I'd like to welcome Dr. Manish Shah. He's the consultant at Department of Ophthalmology at Lilavati Hospital and Research Center, Mumbai. He'll be with us very soon. I welcome Dr. Prateep Vyas, specialist of cataract surgery and glaucoma treatment at Center for Sight, Indore. Welcome, sir.
Thank you.
I also welcome Mr. Anurag Dhingra, who is the General Manager at Zydus Cadila Healthcare Limited. Welcome,
Thank you.
sir. Professor Dr. Sushmita Kaushik would be leading this session from here on. So, ma'am, I request you to please go ahead with this.
Yeah. Thank you very much and thank you, Zydus, for this opportunity of spreading blindness and spreading awareness about glaucoma blindness because uh, often we as clinicians are so frustrated at seeing patients who had the disease for years and years and they didn't know about it. So I'll just start the ball rolling. It's my proud privilege to have my dear friends and senior colleagues, Dr. Pradeep, Dr. Manish will be joining us, Dr. Murli, to join me in spreading this. So, Dr. Pradeep sir, I'll start with you. What is glaucoma and how important is the incidence of glaucoma in India? How should we be worried?
Okay, so thank you, Zydus. Thanks, Sushmita, because it's for the public awareness. So I will go with the basics. About a few decades before, the glaucoma used to be considered as a disease of intraocular pressure. Like we have a blood pressure, we have a pressure inside the eye as well. The normal range of the pressure is around 10 to 22 millimeter of mercury. Earlier, whenever the pressure used to be high, we used to call glaucoma. But over a period of time, our understanding has changed and we have learned a lot about the glaucoma. So now the intraocular pressure has become one of the important risk factor, but not only a factor by virtue of which we can diagnose glaucoma. So nowadays, we call patient having glaucoma when patient has a typical optic nerve features suggesting glaucoma. The optic nerve is the nerve which connect the eye to the brain and correlating visual field changes, which is one of the most important diagnostic modality for glaucoma. And as I said, that the intraocular pressure is one of the important risk factors. So most of the patients they do have a high intraocular pressure, but many of the patients they may have a normal intraocular pressure as well. Now, as far as the incidence of glaucoma is concerned, uh, broadly you can say that in India, 1% of the population is affected by the glaucoma, which translate into around 13 million. 1 crores and 20 to 30 lakhs patients are there, and most of them are remain undiagnosed so far. And the glaucoma is divided into two categories, that is a open angle and angle closure. So almost 50-50%. Or in my practice, I see 30% patients having an angle closure and almost 70% patients having an open angle glaucoma. But remember one more thing, there is a third category which is called secondary glaucoma, which is also very important. And I see almost one third of my patients coming in my glaucoma clinic are having a secondary glaucoma. So that also has to be kept in mind.
Thank you so much, Dr. Pradeep. That was such a wonderful start to get the session rolling. Dr. Murali, I'll come on to you. So, can you just elaborate on the different types of glaucoma that Dr. Pradeep has talked about? And what is the basic difference, and does it matter as to which kind of glaucoma somebody has?
I think it's a wonderful discussion, and thank you for initiating this. And I think you're right. We should clearly say not all the glaucomas are similar, in the sense that we need to know what type of glaucoma is it before we decide to even start off the kind of treatment which we are planning. As very clearly Dr. Pradeep has pointed out, basically glaucoma is a disease that affects the eye nerve. There are so many risk factors like the eye pressure, getting older, having the family history, and so on. So once we know that there's a glaucoma, we need to know what is the type of glaucoma. As he broadly pointed out, we have the primary glaucomas and the secondary glaucomas. The primary glaucomas in which we don't really have a particular reason for the glaucoma, but we have what is called as the open angle type and the angle closure types. So that is only picked up by a eye specialist who has to do certain tests like gonioscopy and certain other tests to see how much of damage is there in glaucoma. So once we know it is an open angle type, that the initial therapy itself is different. Suppose you have the angle closure type, the initial treatments will start off with a laser. And then, of course, there you have the secondary glaucomas in which the glaucoma is due to something which has happened in the patient's so-called ophthalmic history. It could be steroid induced, it could be injury, it could be diabetes related, new vessel bleeding in the eye. So those kind of things, something which relates to even surgery due to some other disease in the eye, we do retinal surgery and so on. Those kind of things can also cause secondary glaucoma. So once we identify the cause, once we classify the type of glaucoma, then the whole treatment and the management is different. So it's very important to know what is the type of the glaucoma. For example, if you have the angle closure glaucoma, which Dr. Pradeep was pointing out, there's a significant number of patients having angle closure. If you don't have the correct type of test or evaluation done by the eye doctor, such as a simple, very simple, inexpensive test called gonioscopy, if the test is not done, everybody is mislabeled as open angle glaucoma and they get treated with medical treatment and so on. The glaucoma slowly gets worse and we pick it up quite late. So it's very important to see a qualified eye doctor who knows how to classify the glaucoma, who knows which therapy to initiate, and to know if it is a secondary glaucoma is the particular cause. Suppose we identify that diabetes is the cause for the glaucoma leading to the bleeding in the eye and so on, we need to address that primarily also.
Yeah. Thank you so much, Dr. Murali. So, Dr. Pradeep, now that this seems to be all very complicated, so does a routine eye checkup help in the early diagnosis in the sense what would be the early signs and symptoms? And is there any age factor? Is there any lifestyle? Who should be worried about getting the disease?
Visiting their ophthalmologist, they must expect that their ophthalmologist would be doing a comprehensive examination of the eye. So when the patient walks in, then we elicit the history. The history is important because we know that glaucoma runs in family. At least some form of glaucoma runs in family. So obviously the doctor will elicit the history. The other thing, not only that it is a genetic correlation, but even like we have a steroid-induced glaucoma. So if we are able to elicit the history that the patient is on topical or systemic steroid for a very long time, then yes, that could be the cause for a secondary glaucoma. So obviously the history taking is important. And then once you start examining the eye, there are so many important things. First, you see the eye itself on a slit lamp, and by doing a good clinical examination, you can assess whether this patient may have angle closer disease or not. That is by seeing the most anterior part of the eye with slit beam. And if it's a very narrow, then the patient, or it's narrow, then the patient is likely to have an angle closer glaucoma. So that is the first thing when you suspect the patient may have a glaucoma. The second thing, when you suspect, when you check the intraocular pressure of the patient, either the intraocular pressure will be checked by the optometrist or will be checked by the doctors. In my practice, I check intraocular pressure myself by application tonometry, but that is a mandatory part of the examination for every patient. So that is the second clue I get for my patient whether this patient may have a glaucoma or not. The third, when I am doing the comprehensive eye examination, definitely I will examine the optic nerve head of the patient with 90 diopter lens, and that will give me a most important clue whether this patient have a glaucoma or suspected to have a glaucoma or it does not have a glaucoma. Then after this combination, what I will do, I will put a gonioscope if required in the patient's eye. It's a small instrument which is put over the cornea, that is most front part of the eye, and we see through the slit lamp examination. And we see the drainage channel of the eye, which drains the fluid from inside to the other channel outside the eye. That is very important because if it is obstructed, then patient is likely to have a high intraocular pressure and glaucoma. So these are the important clinical examination which will take me to the situation where either I will diagnose the patient having a glaucoma or suspect the patient to have a glaucoma or label a patient that patient does not have a glaucoma. So after that only I will advise the battery of investigation which may include the perimetry and the OCT and so on and so forth depending on the type of glaucoma, but these investigations are must. As far as the lifestyle and other things are concerned, there are some things, yes, which are very important for glaucoma. Like, if you have a person who is a trumpet blower, or you have a person, who teaches yoga almost 8 to 10 hours a day, and he does lots of sirsasana, sarvangasana, and so on and so forth. So these are all the people who are more prone to glaucoma because their intraocular pressure goes high very acutely at some point of time. Chronic constipation could be one of the important reasons. The person who has sleep apnea, who snores a lot during sleep, all these patients are at the risk of the glaucoma. Other things, we do not have a great scientific evidence, but the diabetes mellitus probably can cause a secondary glaucoma in many of our patients. So that is an important systemic condition which also kept in our mind while we are examining the patients.
Right. Thank you so much, Dr. Pradeep. And the point that you reiterated is so important that ultimately it is the optic nerve damage or the characteristic optic nerve feature which diagnoses it. And it's important to also maybe tell the patients that the pressure, the intraocular pressure is the only thing that we can modify. And during the course of the day, there might be a time when we are evaluating them that the pressure is not high. And it does not mean that it's not glaucoma just because the pressure is not high, vis-a-vis always thinking it's high pressure. So, welcome, Dr. Manish. I think Dr. Manish has joined us. So, we've gone through what the early detection strategies are and what would be the early signs. So, I'll come to you with once you diagnose a patient with glaucoma, what next? What is the next step that a patient should expect once diagnosed?
So once and the patient has been told that he has glaucoma, the next step is to take care that we always keep the pressures under control and monitor the patient. The first step or the first requirement is monitoring. Some patients are just suspects, you may not treat them, but monitoring is extremely important. So the patient has to be explained very well that you will have to repeat intraocular pressure tests, you will have to repeat your visual field tests and your optic nerve tests from time to time. How often it needs to be repeated, that will depend on how threatening the glaucoma is. The more the glaucoma is acutely affecting the vision, the more frequent the tests will be, and in suspect sometimes it can be just once a year or something like that. The second part of the treatment is the reducing intraocular pressure. That will depend on the type of glaucoma. If the patient has got a narrow angle, doing a laser iridotomy is usually the first step. And patients have to be very thoroughly explained that this is only the first step and it is not a curative treatment. It does not mean that you have done the laser and now you don't have glaucoma. So very often that is a misconception that they have. And second misconception they have is that the iridotomy is done, now the pressure will be controlled and I don't need to put any drops. So that is the second misconception. So this all has to be explained very well to the patient. And then iridotomy, if the patient has got a narrow angle. If the patient has an open angle, then usually we initiate with the medical management, and that also will depend on the severity of the affection and the intraocular pressure itself, and we work out a principle called a target pressure. So based on the evidence we have on that over the years and treatment and so many studies, we determine what pressure would be assumed to be safe for this patient, and then we work around mixing or giving one drug, more than one drug, to achieve that pressure. So that is the second step that we take in treating the patient. And the third step is that once you have started the treatment, you have to watch and see that your treatment is effective or not, whether your target pressures are achieved and whether the glaucoma has reasonably stopped worsening rapidly. So this is the outline, broad outline that the patient can expect to get. Also, some of the side effects like red eye is very common. So usually I go out of my way and tell patients that you can expect your eyes to be a little red and a little sore more than they are now, and don't be upset. That doesn't mean that your glaucoma is getting worse. In fact, that means that you're putting your drops properly. So I use that as a reinforcing kind of instruction, but that also has to be shared with the patient, some of the side effects that they can expect to see with the drugs. So that's usually how I start the treatment.
So thank you, Dr. Manish. Just in addition to that, when you talked about target pressure, how do you know whether the target is that you have set is okay for this patient? Because sometimes some patients get very upset that I was told that my pressures, if they're 16, I'll be fine, and now I'm
Yes.
being told that even if
No.
they're
So
16, you have to.
so that's what I mentioned, that this is the initial treatment. It is an assumption based
Yes.
on the data of other patients and this multi-center studies and our own experience. We assume that a certain patient with a certain kind of involvement and a certain extent of disease would be safe with a pressure of say 16 or 17 or a range. We usually say a range, like we say you should be okay with a range from 14 to 17 or something like that. But this is an assumption. So the
Yes.
follow-up is important, where number one, whether you are achieving the target that we have set, and second is whether the target is achieving what we want, whether it is stabilizing your disease. And if it doesn't seem to be working, we have to rework from base one again, reset targets, and maybe intensify our observations and see if something is not working, or the patient is not putting drops properly. We have to go into all the details of that. Yes. So it's very
Right.
important, and sometimes your target needs to be set, reset, and set maybe 2 or 3
Correct.
times before you get where you want. Yeah.
Yeah, so it's important that the patients understand that we are assuming that you should be stable, but of course, repeated visual fields and the rate of progression of disease will also determine that. Dr. Murali, I'll come to you now. Dr. Manish said that he's going to probably start drops even after a laser for angle closure if the target isn't reached. So the adherence is so important, and the patients can be a little smart. Sometimes they might put the drops a couple of days before coming to you because they know you'll ask them and hold them up. So are there any tips which you use for adherence to the prescribed treatment, and how do you know that the patient is compliant with what you tell?
I think
Dr.
as
Murali? Yeah.
human beings, basically all of us default on standard treatment. Suppose somebody is asked to follow traffic rules, suppose somebody is asked to wear a helmet while driving, or not to cross the yellow line when you drive. I think as human beings, as Indians particularly, we all have the habit of defaulting and making mistakes, and we love to sort of beat the
Be
system.
smart.
We don't like to follow. We don't like to be orderly. So that is our. We have to take that into account. And most of the time, our patients are all human beings, and
Yeah.
asking them to do something regularly. So it's like saying, brush your teeth every day at 6 a.m. At 7 a.m., have your breakfast. At 9 a.m., you do this. It's very difficult as human beings to follow that routine throughout your life. So we have to give a little room for the sort of people to default a little bit and give them a little leeway and all that. So we have to be balanced the difficulty of ensuring the so-called, we call it compliance or adherence is the word which we use. So to do that, what I do is I try to be friendly to the patient. Suppose you
Okay.
threaten and confront the patient and say, "Have you used this? Did you do that? It will make you will go blind. Don't put this. Don't do this," and so on. So first is to have a gentle kind of prodding to see. I will just casually ask them, say, "How many bottles have you used? Did you have a prescription? And how many bottles have you used in the last few months?"
Hmm.
That's one way of knowing that if suppose somebody is using one bottle a month, I would know that he has bought about 5 or 6 bottles in a few months. That's one way. The second is suppose if I use only 2 bottles and he's come after 6 months and I find his glaucoma is getting worse, then I know that he's not used medication. And in the way that you have described that he has probably used it a few days before he came. So that's what we call as white coat compliance, in the sense that they're scared that the doctor is going
Yes.
to find fault with them. They applied a few days before and they come. They apparently look like children in which the pressure is under control. But we know they're worsening because they have not used it. So we check
Hmm.
on their history and how many bottles they have bought and so on, and looking at the eye. Very, very often we'll find at least half the number of patients whom I know will default in some way. The average patient will not apply at least a few days in a month. Many of them will not apply for weeks together. But by and large, we try to enforce compliance by linking it to some activity they do in the day. And the
Hmm.
idea is for a doctor's point of view is to keep the number of bottles they apply to the minimum. Give the
Okay.
minimum medication for the maximum effect. Maybe apply once a day or twice a day. If you increase the so-called complexity of the number of drops to be applied, so one drop is 4 times, one drop is 3 times, one drop is once a day, and they will start applying the less important one, which is the most comfortable, and forget about the rest. So keep it easy for the patient, minimize the number of drops, and make it easy and link it to some activity which they do. I usually say have a bath in the morning or have your breakfast in the morning and remember to tick it off in a calendar or tick it off somewhere and have some way of reminding yourself that you applied the morning dose. Similar in the evening, you link it to some activity like having dinner or coming back from your work and make sure you upload it. Ask some family member to remind you that you have put the drops or tick it off in a calendar or get yourself an SMS reminder. Some of our patients are tech savvy and they have these apps and reminders and so on. Whichever method suits the patient, whichever method works for the patient, we should
Hmm.
try to ensure. I would aim for about 50 to 80% or 70% compliance. Well,
Okay.
100% compliance you will never get in your life. It is the ideal world.
Correct.
You don't live in the ideal situation. If you get a good 70-80% compliance, I am happy.
Okay. Right. Thank you so much. So many tips. Dr. Pradeep, your take on your tricks for the patients. I like what Murali said about counting bottles. That's something that we can take home. What would you do when a patient comes with apparently normal pressures and the fields seem to be not so great? So you're suspicious. How would you check for adherence with them?
Yeah. So, Sushmita, we all are glaucomatologists, and the patients who are coming to us, usually they come by the referrals and usually they are compliant. What I would say, like you have a patient with the diabetes, hypertension, they don't forget to take their medicine or take insulin, but they comfortably forget to put the drop because they don't give importance to the vision until and unless they have a significant damage. As you said
Correct.
very correctly, that if the patient does not have a significant defect, then it is little difficult and tricky to
Hmm.
convince the patient that he has some pathology which might cause a irreversible blindness, obviously we should not create a psychosis kind of a thing into the patient, but still we must explain to the patient in great detail that what kind of consequences or sequelae the patient may have. Fortunately, glaucoma is not like a cancer that it would cause a overnight blindness. So that's why the Murali said that, if the patient is compliant by around 80 to 90% time he's putting the drop, he's comfortable. So yes, I do agree that if the patient does put around almost 25 or 27 days in a month, then the endurance is there and the glaucoma does not progress so far. So we are okay. But to sit with the patient and counsel the patient and explain about the disease is very important and very crucial and critical. So whenever the patient comes to me having a glaucoma, having a mild glaucoma, then I have to explain to the patient all these fine. And whenever I tell about the medicine, I always use a word that you can forget to take your lunch or breakfast, but don't forget to put your medicine. Then the patient they do understand. Many a time, I have seen the patient putting the drop on the airport or in the aircraft in the time. So there are most of the patients who are educated, literate, they do understand about the condition. If someone else is suffering in their family with the same kind of a disease, then they understand more and they are too compliant and they are very good adherent to their therapy. But otherwise, there are many patients who are very casual type of patients and they don't realize the severity of the problem which they may face 5 years, 10 years, 15 years down the line. Like they play with their diabetes and the diabetes goes haywire. Similarly, their pressure also goes haywire, and you keep on checking the pressure doesn't come under control. You do the perimetry, and every perimetry shows some amount of progression. These are the patients who are very difficult to treat and they are hard not to crack, and we have to spend a lot with these patients because we don't want any of our patients going blind just because of poor compliance or adherence. Because it's a probably a very bad thing on our part if we are not able to convince the patient that how regularly sincerely he has to take the medicine. So I will ask the patient to sit with me. I will explain the disease. I will explain it how to put the drops. And many of our patients are very old patients and they are not able to put the drops. So it is better to explain to their kids that they have to put the drops very regularly. There are many patients who come to you, come with the servant. So you have to explain to their servant that how to put the drop, how to do the punctal occlusion, and the many patients they are non-compliant not because of the other thing they don't have the medicine or they don't have the money to buy the medicine, but because of the side effect of the medicine. As Manish has said that he always explained to their patient that the patient may have some sore eye or some redness in the eye, so that you have to explain to the patient. Otherwise, the patient will put the drops couple of days and he will find his eyes are very red and then he will discontinue, he will not put the drop. And all of us knows that all our medication they have so many topical side effects. So that is very important that we must tell to the patient beforehand that he may or she may have some side effect and he has to bear with that, and over a period of time he or she will become very comfortable with the drops. So the compliance, adherence, persistence is very important in glaucoma, and all of us must spend time with the patient to explain about this.
Thank you so much, sir, for all those tips. Mr. Anurag, I'll come to you. How do you think industry can partner with us to improve the adherence to medication in patients? Is there something that you can do, some incentive, some reason for them extra to put drops?
Thank you, Dr. Kaushik, for that question. I think industry has a very vital role to play in the creating the awareness for glaucoma and support the ophthalmologist in their endeavor for diagnosing and treating glaucoma. Well, I think there are two aspects industry can support. One, the product itself. Industry should make very differentiated products, one which are stable in Indian climate conditions, coming up
Correct.
with formulations such as preservative free, where given this is a long-term disease and long-term treatment, and they can with these preservative-free formulations, we can have minimize the side effect which could be related on the long-term usage of the drugs. Second, most important aspect being the financial burden, reducing the financial burden. Now, given glaucoma is usually associated with old age and patients usually would have comorbidities, so there would always be, other medication would be coming along. So if we can make this treatment affordable, I think that could be one of the first steps towards increasing the compliance, where patient can, it doesn't pinches him while he's taking the drug for a long time. Third aspect is on the service aspect of it, where we can, industry can partner with doctors in creating more awareness about screening programs, awareness talks. There are various apps, like glaucoma vision simulators, apps for reminding the medication. So those small things that industry can support the doctors and patient in helping to eliminate the blindness which is led by glaucoma.
Right. Thank you so much. And we as doctors always look for free. So the more free samples you give us, that's the incentive for the patient to come to us, because they think that at least dawai to mil jayegi, so let us put some and go anyway.
Sure.
So we'll change gear a little bit now, and we've talked about the clinical examination for detection of glaucoma. And Dr. Murali, I'm going to come to you now. So everybody is now going high tech. So could you tell us what are the established diagnostic tech, tech machines available? Because so many patients are now carrying pictures of OCTs and fields and whatnot in their hands. And how important are they in the diagnosis? And how much must we insist that we have modern or newer diagnostic modalities for the diagnosis of glaucoma?
Yeah, I think your question is very valid in this day and age in which we know that technology is like really exploding, and you have all kinds of devices, all types of tests available. All of them are, some of them are very expensive, and sometimes insisting on expensive tests turns away the patient and they don't come back, just the
True.
fear of being tested or paying for the cost of the test and so on. So basically, first and foremost, how we all teach our colleagues, our students, and even among ourselves, so-called educating our fellow ophthalmology who practice glaucoma as so-called glaucoma specialists, is that we insist that there has to be a very basic clinical exam. A clinical exam usually means simple things like checking the vision, checking the eye pressure, having a look at the front of the eye, like using a slit lamp and the gonioscope. Some very basic equipment is available with all ophthalmologists. And then having a look at the back of the eye with the so-called the 90 diopter lens, which Dr. Pradeep was talking about, looking at the nerve. This is the bottom line. A comprehensive, simple, basic eye exam, which every eye doctor has. Every qualified eye doctor who does a complete eye exam will be able to suspect or pick up a glaucoma most of the time. That element of suspicion, that element of doubt is always there in some patients, but the average glaucoma patient can be picked up by basic tests. But having said that, once we pick up as somebody having glaucoma or strongly suspect to have glaucoma, we need further testing to see how it has affected the function of the patient. Suppose he is looking straight ahead, how much he doesn't see around him. That is called the field test. Suppose we pick up an early glaucoma and the field test sometimes shows up late. Then we do some little more sophisticated tests and so on. But insisting on a sophisticated, expensive test is not the way to go. And generally, we would advise having a basic eye exam, comprehensive, complete eye exam by a doctor who is qualified to pick up the glaucoma. And the very basic bottom line to check the function would be a test involving the visual field. That as you look straight, how much you look around you is very important. So that test will tell us, is the glaucoma mild, is the glaucoma moderately affecting your function, or is it a severe type of glaucoma? So that would actually impact so many daily activities of the patient. So visual field becomes important. Once you go into an advanced glaucoma clinic and you're under the care of a specialist and so on, then you go on to more sophisticated tests. I think we always insist on basic tests, simple evaluation. We do not confront and we do not scare the patient to believing that technology is important for diagnosis. And of course, once we have some doubt, we always, like, suppose somebody comes in with a headache. We don't do an MRI scan for everybody with a headache. We know who is the one with a headache who really needs an MRI and expensive tests and so on. So not everybody with glaucoma needs all available tests. So we do a basic bottom line, we do a complete eye exam, we will tailor make and say this test is for you, this test is for somebody else, and so on. We don't need to do a battery of tests to diagnose glaucoma. Neither we need a battery of tests to watch for the glaucoma getting worse or watch for the so-called management of treatment of glaucoma once the treatment is initiated. So I think the simpler we stay, the patient also understands the need for doing further testing and so on.
Thank you, Dr. Murali. So that was put so nicely. Dr. Manish, I'll just go on to that. That is it possible that these sophisticated tests can go wrong? In the sense that, is it possible that they can flag glaucoma in a normal patient and vice versa? And is it important that the patient also be aware of that?
Yes, that's also a very important aspect, and we face this day in and day out, is that no test is infallible. So there is nothing, there are always the false positives and false negatives in every test. And therefore, for the diagnosis of glaucoma, each and every test that is done has to be correlated with what the doctor has examined and found in the patient's eye. And it has to, all the dots have to be joined together before we can really conclude that this is a true defect or not. And there are many instances where you get artifacts and you get uh, some kind of false negatives, false positives, which have to be interpreted. And for that, you require the doctor to apply his clinical knowledge and judge each and every test. And even though one test showed everything correctly, it can happen that when the same test is done again after a few months, and something can go wrong with it. And there are factors in the patient's eye also which sometimes cause disturbances in these tests, like if a patient develops a cataract or patient develops some excessive dry eye, also can play a mischief with the tests. So all this has to be taken into consideration when we are interpreting before we advise the patient, and patient has to be aware of that, that there can be things which are other than the disease itself causing changes in the test.
Yeah, because there are patients who unfortunately do walk around with printouts of tests which are done by technicians or done by their friends anywhere, and not done by people who look at glaucoma day in and day out. And it plays havoc on their psyche because a piece of paper is flagged in red, and they think that they have glaucoma. You go on the internet, you see glaucoma is a chronically blinding disease, and there you have a heart attack as well as glaucoma, whether you have it or not. So that's so important. Dr. Prateep sir, I'd come to you and ask you, what do you see in the future? What are the newer diagnostic techniques, and do you think any of them are going to be better than what we have today?
Okay. So, Sushmita, this is for the general public. So, let
Yes.
me tell them that why we do the test. We can diagnose the glaucoma, as Murali also said, that by doing just a good clinical examination. But we do these tests, number one, to confirm our diagnosis. Number two, to quantify, as Dr. Manish was telling, that mild, moderate, or severe kind of a glaucoma. So to quantify that how much defect the patient has developed. And glaucoma is a chronic progressive disease. So we have to assess the progression that also has been elaborated by all of us. So that also we have to pick up at the earliest that the patient is progressing. So for these three reasons, the tests are being done for these
Hmm.
patients. And the most important test is the perimetry, which is still a gold standard. Nowadays, we have started doing the other imaging technologies we have started using, like OCTs and all. So the newer development which are taking place, number one is in the OCT. So why OCT is becoming so important these days? Obviously, it is not that it is a non indispensable. Yes, it is just a complementary to other tests, but not mandatory. But the one reason is that many of our patients they are not able to perform the perimetry well, which is a very subjective test. So we want a good objective test. So the OCT is an objective test. And now the second reason is that we want to pick up the early diagnosis, that the patient has just started developing a glaucoma and you pick it up so that the patient would not progress further and the quality of life will be maintained. So most of the recent development is to pick up the glaucoma at very early stage. And one of the modalities is that, yes, we are seeing the development in the gold standard test, that is a perimetry, the newer strategies are coming out, like we have started using 24 days to see program in our practice. Similarly, there are so many developments are taking place in the OCTs also. Now OCT angiography is available, where you would be able to pick up even what we call a pre-perimetric glaucoma. That means that when the glaucoma does not appear even on the perimetry, and you can pick it up on these devices. So these are a few development. Apart from that, even as were discussing about the gonioscopy, so the non-contact gonioscopy, yet it's not available in India, but it has come by the NIDEC company. So these are all developments are taking place, and probably the ERG test and so on and so forth. But still, yes, we can get away with all these newer advances. The newer advances are some of the fancy tests for the fancy patient, and some are the research tool. But still, for a routine patients, the perimetry is the best test to perform and mandatory test to perform. And sometimes the OCT might be complementary for that.
Right. Thank you, sir. Thank you so much. We'll now shift gear a little bit because we've talked about medication, we've talked about laser. So let's talk a little bit about glaucoma surgery, because that's something that really scares the patient when you say that they have to be operated for glaucoma. So I'll come to you, Dr. Manish. What is the usual or the most commonly performed glaucoma surgery, and what must the patient expect once he has been subjected to surgery? That's something most patients seem to think, that the glaucoma will be cured because I'm being operated. And I think in
Yes,
Hindi it's
exactly.
called kala motia, and so they correlate it with safed motia, which is cataract. So, what would be your take on that?
So this is the first step, is that when a certain patient requires to be operated, we have to go into a lot of details to explain to them that why we are recommending surgery for that patient. Is that first and foremost, we have to make them understand that their glaucoma, usually we are doing surgeries in patients whom we are not able to get good control of intraocular pressure by the medicines and the laser treatments, and the patient's visual field and the function of vision is deteriorating because of this poor intraocular control. So we have to explain to the patient that this surgery is only and only aimed at getting better, lower intraocular pressure and more steady control. It is not going to improve your vision, and in majority of patients, or in a good number of patients, it may actually cause a little bit of disturbance in vision. It will change your number, it will change certain things which you might feel as actually some little mild difference in the vision. But in the long term, when you get more stable and lower intraocular pressure, it is going to save your optic nerve from further glaucoma damage occurring very rapidly. So this point has to be explained very well. The second point that has to be explained is that the success rate of the surgery, though we get good success initially, almost 90-95% patients, we are able to get the reduction in intraocular pressure. But as time goes, these patients' pressures start going up again, because the filtration surgery also starts reducing the amount of fluid it filters. It starts scarring down, and usually it lasts for about 5 years, 7 years. And after that, does not function too well. You may need to put the patient back on medications, and in some cases do repeat surgeries. So this has to be explained, that it is not a once forever kind of surgery either. So that is the second point, that patients take some time to take in, that this is not that you are doing the surgery and you are curing the glaucoma. Okay, some damage has occurred, but after surgery no more damage will occur. That also is not true, because if the pressure control you achieve is steady and good for some time, it will help to control the further progression. But the moment the surgery effectivity starts going down with time, you need to be checked again, and additional drops may need to be given to keep the thing going in a fair fashion. So the third point that has to be made aware is that even after the surgery is done, your checkups with the doctor will continue almost at the same frequency. Your checkups in doing visual fields and optic nerve scans is going to be almost exactly the same as it was before. So all this is not going to change, and the doctor has to keep checking every time that your surgery is working well. And if it is not, the doctor will be in the right time to take necessary steps. The fourth point, which I always explain to the patients, is that scarring is the biggest problem, and we have got anti-scarring drugs. We use them during the surgery, and sometimes after the surgery also we need to do. So they need to understand that cataract is once done, and then after that there is nothing else. The patient doesn't go back into the operation theater. But when a glaucoma surgery is done, a good 20 to 25% of patients in the first month or in the first 2 months may need to go back in the operation theater for probably removing a stitch, taking an additional stitch, giving an injection, or doing a needling procedure. Something they are not big procedures, but they need to be going back in the operation theater. So it is pretty routine, and they should not take it as a sign that your surgery is failing. Because very often when you tell the patient, oh, tomorrow you need to come to the operation theater, I need to do this, they immediately miss a heartbeat, because they think that means that my surgery has failed and doctor is going to do again something. It's a pretty routine thing to go back in the operation theater for some small procedures after a glaucoma surgery. That needs to be explained to the patient very well as well. And the last point is, all glaucoma surgeries which are filtering carry the risk of getting infected, and these infections can be sight threatening, can wipe out your vision. So anytime there is any redness, discharge in the eye, it should not be taken lightly. It should be treated immediately and aggressively by an eye surgeon. So that is also a very important message they need to know after they are going to be operated.
Right. Thank you, Dr. Manish. That was very nicely put. Dr. Murali, I'm going to come to you that a lot of these patients are in the elderly age group in which they also have a cataract. So there are a lot of apprehensions when sometimes we tell them, look, you have both cataract and glaucoma. Sometimes we separate the two, sometimes we do them together. So what would be your take on telling a patient, when would you do them both together and when would you separate out both surgeries?
I think that's a really important aspect of so-called counseling a patient as to what is the problem which is actually affecting the vision of the patient. Most
Yes.
often, the patient is actually concerned about the vision because glaucoma remains silent. That's why we call it the silent thief of sight, and doesn't really apparently affect the patient in any way. And cataract is the one that really affects the vision. So when we look at the patient with so-called cataract and glaucoma, we call it coexisting cataract with glaucoma. It's actually basically two troubles. You have double trouble, you have cataract and you have glaucoma, and you need to deal with both. Suppose the glaucoma is very mild and is getting well controlled with, say, one medicine, and patient is able to use the medicine properly, is able to come back properly for checkup and so on. We sometimes do just the cataract alone and maybe ask the patient to continue to follow up for the glaucoma and maybe use one medication if needed for the control of the pressure. Suppose the glaucoma, let us say, is moderate or even advanced and the cataract is significant, then we give more importance to the glaucoma and make sure they understand that the glaucoma control is very important, unlike the cataract, which can actually wait for some time. We prioritize, suppose the glaucoma is very advanced, the cataract is very mild, we'll end up doing a glaucoma treatment first and then wait and say we'll do the cataract later. But we also have the option of doing combined cataract and glaucoma, which will actually improve the pressure, improve the vision, at the same time control the pressure. So that kind of decision making regarding which to do first, which one to do, and whether to do combined or not is best left to the treating doctor, the treating surgeon, the skill and the availability of technology and the kind of procedure which we are doing. We have a lot of new methods for cataract surgery now, which actually enables us to do the cataract very comfortably and conveniently for the patient without his realizing, and the glaucoma surgery success also doesn't get affected because we can do the glaucoma surgery in one part of the eye and the cataract can be operated on a different side of the eyeball. So we don't really need to interfere and do both in the same site, as we call it. So a lot of advantages in technology, a lot of advantages in doing both at the same time. We can avoid doing two procedures, make the patient come twice to the operation theater. But the judgment as to which to do first, whether to do both together, whether in certain types of the angle closure, narrow angle glaucomas, sometimes taking out the cataract at an earlier stage is actually controls and changes so many things in the front of the eye. So that decision about taking out the cataract at an earlier stage in angle closure glaucoma is another aspect of the management also. So the judgment is best left to the treating doctor, and discussion with the patient as to what exactly is being done is very, very important. Because sometimes patients simply turn around and say, "Have you put the lens in my eye?" When we have done only a glaucoma surgery, or when they say, "You put the lens in my eye, I still don't see, my field does not improve because he has advanced glaucoma." So I think counseling, clear explanation, giving the patient the time for the information to sink in. Sometimes what we tell casually in a 5-minute conversation, the patient simply doesn't understand. We repeat it again, we
Very
counsel
true.
again, we give it in writing, we ask the attendant to explain, we give them one more session of counseling before we undertake a procedure which is sometimes not reversible. We can't go back and undo what we did. So therefore, it's
Yes.
important to counsel, important to discuss with the patient as to what actually the patient's expectation and lifestyle is. Suppose patient is sitting at home most of the time and doesn't do much of activity, doesn't drive at night, then so many things change in the management. So I
Hmm.
think discussing the patient's lifestyle, the cost, how the attenders take, the caregivers take care of the patient, and of course our way of deciding which is a priority in management. I think there's so many decision making things to be done. I think it's not an easy answer to give for every patient, and
Yeah.
every eye of a patient is treated separately. So I think
Correct.
a lot of discussion and counseling has to go on.
Yeah. So counseling is so important in all that we do every day, and each patient, as you say, the same thing, same disease, manifests differently, and the expectations are different, and treatments also. So we're nearly running out of time, but I would like to close with eye to the future again. And Dr. Prateep, if you would wind this up with what is exciting for the patients to look forward to. We've been asked this so many times. Isn't there any gene treatment? Isn't there any stem cell? Because you have wonderful things on WhatsApp University and Google Baba. So, what is the scientific take, and what should we tell them when they
I
ask
think
us
we should
these
end.
questions?
I think Dr. Smita, we should end on a positive note and give a
Okay,
positive thing that basically what we are doing, we have come a far way since we early had understanding of glaucoma. We now have a
that's
lot
true.
of drugs. We have so many methods to treat, and let's give a positive message that glaucoma is not all blindness. And even though we have so many methods to treat and we have aggressive methods to treat, we still have positive outcomes. And most of our patients come back to us for 10 years, 20 years, and even 30 years, and they still do well. They're able to go about their activities. So let's end on a
Correct.
positive note.
Okay, done. Dr. Pradeep, you're okay. We'll do it this way. We'll have 1 minute of positivity from all of us. So, Dr. Pradeep, starting with you, sir.
Yes, so every patient wants that there should be some objective test to diagnose his condition at very early stage. So yes, we are coming up gradually with the objective tests which may be highly sensitive and specific. Patient want that he should get rid of putting up all these drops regularly, and it should be either one time treatment or maybe a long term treatment. So yes, we are coming out with some solution where we might be able to inject some
Yes.
drug intracamerally, which may be effective for 6 months or 1 year or so. So that could be one good news for the patient, so that they should not be bothered about putting up the drugs. But the most important, what I would like to emphasize is that every single patient who has gone blind always come and ask that is there any solution for that, or is there any solution will be there in the future. So yes, the people are working very hard. They're struggling very hard. People have started putting the bionic eye. The bionic eyes are not so great helpful. The gene therapy, as you said earlier, yes, the people are working, and for some Leber's optic neuropathy and so on and so forth, that they have started using it with some success. So we hope that maybe 5 years, 10 years down the line, we might be having something to rejuvenate the optic nerve as well.
Thank you, sir. Manish, your take, your 1 minute of positivity.
So I would like to say something different from what has been told by all the others. And what I would like to tell, I always tell my patients is that you have to understand that for every coin there are two sides. So yes, getting glaucoma is a dark side. It is a progressive disease which can potentially make you blind. Yes, that is not a easy thing to digest. So let's look at the other side, is that today we have tests which can very reliably tell us what is exactly going on, which we did not have. Say 15 or 20 years back, the way we used to check patients, we weren't really sure whether they are getting worse or not. Today, we are much better off, even with the technology which is available right now. Obviously, as Dr. Prateep said, it's going to get better with time. So we are in a position to diagnose the disease before it really causes any problem at all. We are in a position to keep checking and make sure that it stays there. We are in a position to give you various options of treatment. If one doesn't suit you, the other. If there are so many options, many more options available. But there is one big but over here, is that you have to understand that you have the disease, and you have to decide to be proactive about it and take up all the opportunities which can only come if you come for your regular eye checkups and keep checking, and then only the doctor will be able to guide you correctly. So the positivity is all there, but it is, you have to make one step towards the positivity. And if diagnosed early, you can be quite sure that in your lifetime you are not going to land up with serious vision issues. So that is the kind of situation we are in today.
Mr. Anurag, your take from the industry?
No, I think Dr. Manish and Dr. Vyas, Dr. Ariga already summarized it well. I think early detection is the key. We have right now the best tools available, and if we are able to detect early and we have the right medication, perfect doctors in India, I think we can really tackle this issue very well. And right now the diagnosis rate is 10%. How is that? Even if we improvise this, we can save many people from turning blind. So
Correct.
I think we scenes have improved over the years, and look forward that things get better.
Murali, your last, not the least.
Yeah, I think I always tell the patient that as long as you stay with us and as long as you stay with a doctor who's
Correct.
comfortable for your management, there's a lot of positivity that people don't go blind if you are following the standard kind of protocol for treatment. Of course, we have the occasional patient who goes downhill regardless of what we do, but the average patient does well. They continue with their lifestyle, do a lot of things, whatever they feel like, nothing really interferes with their day-to-day activity. They continue their businesses and continue their profession and continue to drive and do everything else. And that is the positive take home, that most people do well with treatment, and as long as they continue with the treatment, and it's good to stay positive. And having a small limitation like having a glaucoma is not going to put away and put you down as that you can't do anything in life.
Thank you. I think we're just closed in time. So I thank everybody. It was a wonderful session. I had lots of fun. All teachers love asking questions. So it was very nice for me, and I hope all of you enjoyed it as much as I did. Thank you.
Thank you.
Thank you, Professor Kaushik, for so expertly leading the session for us. I also thank all our expert panelists for taking out your valuable time and sharing your expertise with us today. I also thank our partner and all our viewers for staying with us till the end. We greatly value your time. Until next time, stay happy, stay healthy, stay safe. Thank you.
Thank you.
Thank you.
Bye.
Thank you.